Hey, so as it's just gone 2 o'clock and it's just gone 1 o'clock where I am, I'll kick off and say you're very welcome to this afternoon's webinar for World Arthritis Day, entitled "Informed Choices, Better Outcomes." My name is Peter Boyd. I'm the chair of the EULAR PARE committee, and you're all very, very welcome. Just to get started on our couple of house rules that I did mention already. This webinar is being recorded and it will be shared by our EULAR YouTube channel afterwards. And please mute yourselves if you're not speaking, or you will be muted automatically. I'm joined in presenting this webinar by my good friend and colleague Susie Macri. Susie, would you like to introduce yourself?
Yes, hello everyone. Very good welcome to all of you. My name is Susie Macri, and I am a member of the PARE committee and the former chair. And it's my great pleasure today to coordinate this webinar with Peter. Before we start, I'd like to welcome our guests for today, our speakers, and I would like to thank you very much for accepting our invitation and for being here today to celebrate World Arthritis Day. A very warm welcome to Uta, Minnie, and Simon.
That's excellent. Thanks very much indeed, Susie, and yeah, we'll be hearing more from the guys as we go through today's webinar. Just a little background, all of us are well aware of World Arthritis Day, but World Arthritis Day 2024 is focused on access to information, and this is particularly relevant in today's evolving and rapidly evolving digital worlds. And you know, we're faced with a really overwhelming amount of information. We have access to information, and it can be empowering. But the amount of information that we have access to can lead to misleading information. It can make it challenging to find accurate and trustworthy guidance. So the goal of what we're looking to do is to make evidence-based, informed choices possible for people living with RMDs. And that's what we're going to really focus on as we go through this webinar today with our presentations. It's a global awareness day, and it's really about increasing knowledge of the existence and the impact of RMDs among all audiences. So we have people from different pillars of EULAR presenting today and speaking at our webinar. So we're really looking to share this information as far and wide as possible and make sure that all of our people are making as many good informed choices and having those better outcomes afterwards. So join the campaign, check out the website, and there's lots more things to discover, including infographics, the 2024 World Arthritis Day Toolkit, and there's a dedicated podcast coming soon as well. Just quickly, I'll go through our agenda for today. So myself and Susie have obviously welcomed you all, and I'm delighted to see so many of you joining us. We will then go through a talk from Simon on the information to action, health literacy, and empowered decision making. We then hand over to Minnie Day, and then we have another presentation from Uta. We will then have time for questions and answers, and we'll moderate that as we go through. And I believe that Susie, you'll introduce Simon now to give us our first presentation, and just let everyone know about the format for questions and answers as well.
Yes, it's my pleasure now to introduce Simon Stones, who is our chair-elect of the PARE committee, and is also a medical communication specialist and patient advocate. And welcome, Simon, and the floor is yours.
Thank you, Susie. I'm really delighted to be here to kickstart our World Arthritis Day webinar, thinking about health literacy and how we make sure that people living with RMDs have access to information so that they can make informed choices and decisions to impact their healthcare. But I really want to start with a definition of health literacy. And so according to the US Office of Disease Prevention, their initiative called Healthy People 2030 gives two really nice definitions of health literacy. And the first one relates to personal health literacy. This is focused on an individual level, and it's the degree to which individuals can find, understand, and use information and services to help inform their decision making related to their health for themselves and also for their loved ones as well. And then there's organisational health literacy, which I think is particularly relevant for patient organisations, because it's how organisations make sure that information for their members and their communities is equitable for all members of the community, to help them make the same informed health-related choices and decisions to help impact their health and well-being. But it's really important to remember that health literacy is contextual. And what I mean by that, there's lots of different factors which can influence how people's health literacy changes, and it will change over time throughout people's lives and also under different circumstances. So for those of you who have an RMD, try and think back to when you were diagnosed and, those periods of stress when sometimes it's quite difficult to decipher what information you can trust and what information you need to be able to make those next steps. So we know health literacy does change, but there is that basic level and how different, which I'll touch on shortly, how different factors influence people's health literacy over time, but we know it can change. And so really for organisations providing information to people living with RMDs and indeed other health conditions, they really must understand their audiences. And we know different audiences have different needs. So people who have been living with RMDs for 5, 10, 15 plus years will have different information needs to people who are newly diagnosed and needing to access information. So it's really important that you understand the purpose of the information that you're trying to get out there and make sure that it is tailored to the individuals you are trying to reach. And then linking very closely to health literacy is health numeracy. And again, this is probably a phrase which is used less commonly, but is really, really important, particularly within what we do in terms of providing information for people with RMDs. And so the Centre for Disease Control and Prevention in the US define health numeracy as a person's ability to understand clinical and public health data. And again, to understand it to make informed choices and decisions about screening and treatment options. And again, there are two types of health numeracy. Subjective numeracy, which is an individual's confidence to understand data, but then also objective numeracy, which measures a person's actual skills regarding maths. And next slide, please. So what is the link between low health literacy and health numeracy and then poor health? So there's very clear evidence which shows that people with low health literacy find it difficult to manage medicines, for example. So that could be understanding doses, understanding when to take different treatments, being able to interpret test results. And again, unless you've got medical knowledge and training, then when you receive those test results, a number on paper doesn't mean very much. And we can automatically think, how could that be improved by having a bar showing the normal limits and where that reading is. So people without access to that kind of level of increased access to information will struggle to interpret those results. People with low health literacy also have less ability to compare treatment risks, which we know can be a really difficult decision to know what is the right decision to make regarding a new treatment, for example, and understanding risks such as infections and other potential complications. And we know generally that people with low health literacy are in worse health, and we really see that on a population level because individuals and populations with low health literacy ultimately have higher healthcare costs because they need to use healthcare services more because they've not had the right information when they've needed it. They actually use preventative services much less, so thinking about screening programs and vaccination programs. And sadly, people and populations with low health literacy do have a reduced life expectancy. So it's not something which we can overlook. This is something which we all have a collective responsibility, whether that's health professionals, researchers, patient organisations and policymakers, to help make sure that we make information accessible to people so that they have the best opportunities to thrive. And there are certain characteristics which increase the risk of having low health literacy. And these are really important characteristics for patient organisations to be aware of, because then you can help to drive targeted interventions to these particular groups of people. So particularly people older age, people with limited education, those with lower income, chronic conditions such as RMDs and disability, and then also refugees and migrants and people whose, particularly in the UK, people whose language is not, first language is not English. And that links very closely with misinformation and disinformation, which I think, as you're all probably aware, with social media, with generative AI, with the spread of fake news, we are seeing an increasing amount of information, which is great in one sense because people are talking more about RMDs, for example, but then that also can be tied with, there is just so much information. It's actually what the World Health Organization described as an infodemic. There's just so much information. It can be really difficult to understand what is true, what is the truth, and also what can I trust. And there are two types of false information which are particularly relevant when we're thinking about health literacy, and that's misinformation and disinformation. Now, misinformation is simply false information that was not created with the intention of hurting others. And that could be sharing a social media post, for example, which was shared with good intentions because people thought they saw a new piece of news and thought this would be useful for the community. And it turns out actually it has some false information in there which could be potentially harmful, but again, it wasn't shared with the intention of causing harm. And then the more concerning type of false information is disinformation, and this is created with the intention of profiting from the spread of disinformation and also causing harm. And unfortunately, this does exist. So we really need to be aware that these are challenges for our communities, and we need to try and support our RMD community as much as possible to make sure that they aren't subject to this kind of false information. And the visual, I think, is just a nice example from the World Health Organization, which just shows how one singular piece of news can be spread so many times, an exponential number of times, simply because people have not necessarily been able to understand, okay, can I trust this? Should I share this with people? Is it recognized? And you can get many different versions of the truth. It's a little bit like you might say Chinese whispers, which one starts with one point and then you end up with different end results which don't necessarily reflect what the original meaning was supposed to be. So with that, how can we help people decide what and who to trust? And again, this is a really nice top tips infographic from the World Health Organization, which helps people to just think a little bit more critically about the information that they're receiving. And we've included some of these points on our World Arthritis Day infographic as well. So really recommend that you have a look at that on the World Arthritis Day website and share widely, because we want people to be thinking a little bit more critically. In an ideal world, we shouldn't be having to do this, but again, this is a reality which we face. So we want people to think about the source and to assess the source. Where did it come from? Is it from a reputable source? And to also go behind the headlines. And we see with tabloid news outlets as well that there can be some quite sensational headlines. I think in the RMD community, we see those all the time about a new cure for psoriatic arthritis, for example, or I've cured my RMD with a magic potion. And these are journalists do this to attract attention, but again, the headlines may lead to false hope. They can be provocative and they can also be damaging. So we want people to think beyond the headline and actually to look at the information. And I think that links really nicely with the third point. So thinking about the author, is this somebody who is credible? Is this a researcher, for example, who has produced this? Is this a reputable patient advocate, for example? Checking the data. And again, I think there's more which can be done to make sure that people can see this is new and recent news, because we know research changes, we know that information changes over time. So if something is from 10, 15 years ago, actually, is that a relevant piece of news to be sharing? And then sort of 5 to 6 and 7 really look at the supporting evidence. So again, thinking about the source, which we mentioned in point 1, but also, is this backed by research? Is this endorsed? And for example, if you saw that these are backed by the EULAR recommendations, actually then you can have some level of confidence that these are evidence-based, that these have been developed by experts, and you can be more likely to trust that information. think one which is really important for us all to think about is about checking our own personal biases as well. We all have a different perspective on the world, and sometimes we can have those unconscious biases which can influence the information that we share and the sort of the language and the tone that we use. So it's really important for us all to think about, are we presenting this quite objectively without our personal opinions, which may or may not be true. And then it's always really good to turn to fact checkers. And I know a lot of news outlets are now talking about having fact checkers as part of their news that they deliver. But there's lots of different organisations as well which can help to give that fact check, so people have that confidence and that seal of approval that this is factual information. And for patient organisations who provide information, and we know are probably one of the first ports of call for patients and other family members with an RMD, how can you make information more easy to access, use and navigate? And so I always give these 3 examples. So keep it simple, check the understanding, and then consider different formats as well. So in terms of keeping information simple, you really need to begin by understanding your audience needs. And I think, as I expressed previously, those needs differ. So somebody newly diagnosed will need, for example, juvenile idiopathic arthritis to be spelt out and to be explained, whereas somebody who's lived with JIA for 20 plus years, for example, may not need to have that level of information, but may need different information to be presented. So it's about understanding the audience needs and tailoring information to those individuals. And the recommendation is to keep the reason age to 9 to 11 years, just through a simple basic understanding, which it's not, and for me this is really important, it's not about dumbing down the science or the information, but it's making sure that it's accessible to people at that reading age. And then there's some really practical things you can do with information. So keeping sentences short and explaining abbreviations when they're first mentioned. And then if you need to use complex words, which there's some words which you can use plain language definitions for, but sometimes you need to explain terms. And so if you need to include complex terms, then explain it or include a glossary so that people have access directly to the information so they don't have to go looking. And when you're developing information, it's really important that you check understanding. So involve your target audience early on to ensure that the language is correct, that the tone is easy to understand, and that the information feels relevant to them. And it's also really good to get other team members to review and obviously different external reviewers to look at the work that you're developing, just so you have all those different perspectives addressed early on, so then you avoid the issues once that information has been published. And then I think really importantly is to consider different formats of information. So we all learn in different ways and we all absorb information in different ways. So it's useful to try and present in as many possible formats as you can, particularly thinking about using icons and infographics, animations and videos. And I know some organisations are restricted by resources, so you have to obviously do what you're able to do within your means. But we certainly know that a lot of people are visual learners, and actually breaking down lots of text using different kinds of visuals can really help to convey messages and for that information to be retained. And this relates particularly to using presenting numerical data as well. So thinking about those donuts to represent percentages, thinking about visual icons as well. So if you're trying to convey 60%, that you could have outlines of 10 people and have 6 coloured in a colour. So that's 6 out of 10 people. So trying to make those kinds of mathematical data more accessible to people in an understandable way. And I think this is just an example from publication that I was involved in earlier this year. And you can see the text on the left is what was in the manuscripts. It's not particularly exciting. It doesn't necessarily jump out. I've bolded the key data in there, but it's not necessarily easy to understand. And I think you can just see from the plain language summary which associated this, just how that information was pulled out really, really easily. So, rounding numbers up so that the number of patient authors was around 2 patient authors, and then actually listing the different kinds of data which came out of that kind of research. So, and these are really simple. It doesn't need to necessarily be super technical or super super visual using, programs which you may not have access to, but it is just about pulling that information out, making sure it still reflects the data that has been published, but it's actually more accessible and people can glance and can actually understand what the key messages are. I think with that, I have included a number of resources. There's lots of health literacy as a increasingly talked about subject, and there's lots of resources on there, certainly from some of our health system here in the UK, and there are a couple of organisations which I think I would recommend you certainly look at. So the Patient Information Forum is one of those, because I have lots of information about plain language, and there's also a couple of examples there of toolkits, the plain English language, and also some alternative words for complex medical and scientific terms. And I think the key message is minimise the effort that's required to understand key messages with the information you're trying to produce. We want to make sure information is accessible. And so sometimes it's good to take that step back and think, okay, if I was in the shoes of an individual newly diagnosed, for example, what are those key messages? And, from this piece of text, do I understand that? How can I make that information more enticing so people can learn and retain that information and then make those informed decisions, which we know need to be based on evidence? So I look forward to taking questions later on, and thank you for listening to my talk today.
Thanks indeed, Simon, and really fantastic to get that overview and have a look. And we're seeing the emojis and the emoticons, visual aids there to let us know that went down well. And if you have indeed minimized the effort required to understand the key messages, we maybe won't have too many questions coming through. But if you do, and you have any questions coming up for yourself, please put them into the chat box, the chat function, and we will come back to them at the end of all the speakers. So you don't have to try and remember them. You can put them into the chat, or also you can raise your hand at the end of all three speakers. But for the moment, thanks indeed, Simon, for that. We're going to move now to Minnie Day, who is a clinical research fellow and registrar in rheumatology and internal medicine at King's College in London. And we're looking forward to hearing about the role of education in RMD care. So Minnie, looking forward to listening.
Thank you, Peter. And also thank you to EULAR and PARE for inviting me to do this talk for World Arthritis Day. Next slide, please. So just a little bit of background about me and where I'm coming from to address this. So as Peter mentioned, I'm a clinical PhD fellow and a trainee rheumatologist. And my focus is really on social determinants of health with a focus on health literacy. So really enjoyed Simon's talk there. And I also sit on various committees and subcommittees for EULAR as well. Next slide. So these are just a few of the topics that I'll be touching on today. Really, the aim is to help patients on the call and clinicians alike and healthcare professionals to give you some tips and tools on how to improve patient education and empowerment. Next slide, please. So I just wanted to follow Simon's talk by just raising something that both healthcare professionals and patients do get quite confused with. So health literacy is not the same as education, but they are closely related. So an example would be that health education has the potential to improve health literacy. Next slide, please. And it really is an important thing to consider, everything that Simon was talking about. These are just some stills from a talk I gave earlier this year. And I was really talking about education, access and empowerment really underlying health literacy. So I'm really pleased to be able to talk about education and empowerment today. Next slide, please. So this slide will be very familiar to anyone on the call who's been diagnosed with an RMD. So, you get symptoms. It may take weeks, months for you to go to someone to discuss them. Many things can impede that. And that may be your GP, for example, or family doctor, or it may be another health professional. Hopefully you'll get referred to rheumatology at some stage, and then follows the investigations, diagnosis, and hopefully some treatment. Except it's not that simple. So if we could just have the arrows up, please. I've just thought about some examples that I've seen from my clinical practice where the process can be delayed, or there may be sort of bumps in the road. And when you get to the treatment stage, you may not tolerate it and it may not work. And those are just some examples. And so really, I'm hoping to give you some tools by which to manage all of this and to help you get through that journey. Next slide, please. And here is where patient empowerment comes in. So according to the World Health Organization, this is a process through which people gain greater control over decisions and actions affecting their health. Next slide, please. And this has 4 key components. It comprises understanding by the patient of his or her role, acquisition by patients of sufficient knowledge to be able to engage with their healthcare provider, patient skills, and a facilitating environment. Next slide, please. This is just a schematic from one of the pieces of work I've been involved in this area. And we asked patients and healthcare professionals alike as to what they feel is the ideal multidisciplinary team for a patient right at the start of their journey if they're diagnosed with inflammatory arthritis. And everyone agreed the patient should absolutely be the core of every bit of decision making. And they may immediately be surrounded by, of course, their family and carers, as well as the rheumatologist, specialist nurse, and GP. And then after that, we get further evading circles of other people that may be involved in the care. But the key thing is, particularly for health professionals, is to identify those individual people to be involved in an individual's care, which will vary from patient to patient. And this is also, in terms of the patient's point of view, to know when to not be afraid of asking for help from these people. But of course, if you don't know they exist, you won't know to ask for them. And so, first of all, with patient empowerment should come greater awareness from the healthcare providers for when the patient can ask for these and when they should need them. Next slide, please. So then follows self-management. I'm going to come on to the EULAR recommendations for this in just a minute, but really this is comprised of 3 factors: peer support, self-management education, and health coaching. Next slide, please. So these are the lay summaries from the self-management guidelines led by Dr. Nikki Foru around 2 to 3 years ago. And these were just, it was a toolkit by which people who are diagnosed by inflammatory arthritis can help to self-manage their condition. If we go forward. And really, there's quite a lot of recommendations that were in this particular document. Then they are summarized in the table on the right. I don't expect you to read it, but it's just to show you that there are quite a lot of components to this. And there's really 3 overarching principles. So self-management implies taking an active role in learning about one's condition and in the shared decision-making process. The point number 2 is self-efficacy has a positive effect on various aspects of living with inflammatory arthritis. A lot of the points within this document, it should be noted, would apply to all RMDs. And the 3rd point is that patient organizations often provide valuable self-management resources. And that's the point I'll come to in just a minute. If we go forward, please. And just giving a nod to our friends across the pond, the ACR just recently celebrated their, or marked their Rheumatic Diseases Awareness Month. And they focused on self-management for that whole month. And so there's some really good tools, just as there are on the EULAR website for this. And I really like this infographic, which just shows 5 key steps you can take to help with your self-management. Moving forward, please. So we come to the role of patient organizations and charities who do play a key role in the care of people with RMDs. This is a quote from the Lancet Hematology Journal, which was published during the COVID-19 pandemic, during which patient organizations were really key, especially for those who were immunosuppressed or had chronic conditions and couldn't easily sort of go out and into society because of the need to shield. So apart from money and care, many charities provide trustworthy information resources for patients and families. Beyond direct service provision, charities have important roles in the healthcare sector, from representing the patient voice and advocacy to addressing socioeconomic disparities. Move on to the next slide, please. I have just taken a couple of stills from some of the charities that I refer patients to myself in the clinic. I've only given 2 examples here, but of course there are plenty more, and they will vary from region to region across Europe and beyond. So I quite like the Lupus UK website because they have these lovely videos, which just as simply as possible for a complex disease like lupus, try to explain the various aspects. And this is just one about the symptoms of lupus. And I also quite like them because it's a good way to show relatives who are maybe quite young, and there's an adult in the family with lupus, about their disease, or if a young person is diagnosed with lupus, it really lays it out quite clearly what the disease involves. And the next slide, please. So in the UK, our National Rheumatoid Arthritis charity is NRAS, and I think I sort of tell every newly diagnosed rheumatoid arthritis patient about this website. It's fantastic. And I've just shown a still of the SMILE RA program, which is the self-management learning environment. And so really we're trying to instill self-management and other tools in addition to pharmacological tools right from day one of people having the condition. So they know they're not alone, there's people they can turn to, and other resources as well that they can turn to. Next slide, please. Now, Simon also discussed this, and I think it was mentioned in Peter's introduction, but increasingly there is more and more information available on the internet. And also it's probably just a natural instinct as well to maybe Google what you have after you've been given a new diagnosis. We know that patients who are under stress during their first appointment, maybe don't have family members with them, they don't take in most of what we say in that first appointment. So it's really crucial to let people go away with leaflets, with access to your own team, but also give relevant internet resources as well. So if we just have the first icon up, it's very common in the UK to give newly diagnosed patients, whichever disease they have, information from versus arthritis. I tend to include the link in every letter I write. And it has excellent resources on medications, living with an RMD, and about the different RMDs in general. But this is obviously a really good internet resource. And as I say, there'll be similar ones worldwide. If we just have the next 3 icons, please, thanks. So Simon also touched upon the Patient Information Forum. They've recently started a program where clinicians can gain what they call PIF ticks, so ticks in this blue-greenish logo color, which when they're creating content, they can ask for it to be verified by the Patient Information Forum. So if you see this colored tick on a piece of information online, whether that be social media or otherwise, it has been verified by the PIF group. YouTube Health is a fairly new sub-organization of YouTube. So they are increasingly realizing that people are creating health video and health content, whether rightly or wrongly, to upload to YouTube. And so YouTube Health are increasingly trying to verify clinicians to show the audience that this is a verified clinician and this is verified information. And finally, there is the World Health Organization, who are also trying to fight misinformation online. So I am actually a member of this program, and clinicians have to sort of submit all of their data and prove that they are a clinician. And then World Health Organization will verify them through their checks. And so it just helps both the creator and the audience to know that this is verified information, essentially. And there are other programs which are up and coming. This area is growing exponentially. So I'm sure we'll see more of this in future. Next slide, please. And just finally, obviously, there is EULAR, which produce lots and lots of information to people with new diagnoses and existing diagnoses. Just put a couple up here. So EULAR Advocacy and the manifesto have plenty of material just to remind its audience of what the important work they're doing, but also what they're doing specifically for patient care and raising awareness. And I mentioned the lay recommendations as well, which are very useful and a good read. I recommend visiting the website, particularly if you want to be more aware about what EULAR are doing on a guidelines and recommendations front. Next slide, please. And of course, there is EULAR PARE, which is why you're all here. And of course, they produce many webinars and information sources throughout the year. Next slide. And so that ends my talk. I hope it was useful. There's some just information links there, including all the sources I mentioned. Thank you for listening. Happy to take questions at the end.
Thank you very much, Minnie, for this very interesting presentation. I think you stressed very well the importance of self-management in all this. And yeah, this is what empowers patients to get more educated and thus have a higher literacy, health literacy. Thank you for that very good presentation. And it's my pleasure now to introduce Dr. Uta Kills, who is a rheumatologist at the Ruhr University in Bochum, and also the chair of the EULAR Quality of Care Committee. Uta, please, the floor is yours.
Susie, thank you very much for the introduction, and I would like to thank also EULAR for inviting me to give an overview about the EULAR recommendation system and their implementation. And I'm happy to present these data on behalf of the Quality of Care Committee and all the task forces that produces verified information and trustworthy recommendation so that you can rely on this information. I'm not only overlooking the process of recommendation in the EULAR European context, but I'm also the lead of many national recommendations in Germany. So Susie, you can proceed with showing my slides. And for that, I might have a conflict of interest, but I hopefully did not have that for this presentation. So I would like to show you what the variation in quality of care worldwide. You do not have to check the figures in detail. What I would like to show you here, or as a symbol, there are so many different processes in the healthcare system. There are so many different structures in the different healthcare system that it's really a challenge to overlook all these processes, to understand all this structure. And I guess it's even more challenging for a patient to have a clear view on the patient journey, on their management, and it's really a challenge to find guidance. In the previous two talks, you have heard about different components on health literacy, on how to get information, and also who is providing different sources of information. And EULAR has established a really strict structure to provide evidence-based knowledge, to generate also a structured reporting system, so that EULAR is aiming to empower patients to manage their disease and to also participate in a shared decision-making process. So what I would like to show you in the next 10 minutes is the process of the recommendation system, and to provide also the scientific knowledge about this topic. So please show the next slide. So I think you understand we have a really huge variability of unsorted information in the healthcare system, and these might also have an influence on quality of care. And what recommendations are doing to ensure the quality of care, they are just sorting and prioritizing information, and then provide this information in a structured way. So this fruits are really to symbolize the process, how we would like to present the evidence-based information to physicians and to patients. Please depict the next slide. And I would like to show you the 3 main steps of EULAR recommendation to provide you with sufficient knowledge and to really develop this evidence-based recommendation according to a structured process, which also following international guidelines of evidence generation. So you will start with a lot of unsorted information. And the very first step is that the task force that would like to develop a specific recommendation ask themselves about the main topic and the main domain. This is an example of the EULAR recommendation for psoriatic arthritis, addressing the medication in this disease. So the topic is psoriatic arthritis, and the 2 main domains are the efficacy of the medication, but also the safety of medication. So we are starting this process with a systematic literature research, and in the right upper corner you will see a flow diagram with all the different manuscripts that are reporting trials of medication in psoriatic arthritis. And you see that they start with a number of almost 4,000 different references. And in a structured selection process, the task force checked all these manuscripts and finally decided to base their decision on 38 manuscript reporting efficacy data and on 24 manuscript reporting the safety data, so that you really have a huge representation of all the important trials that have been published in a recent time frame for psoriatic arthritis. The next step is to have the level of evidence and also to think about the risk of bias in these manuscripts. In the left lower corner, you see different types of manuscripts and study designs that are the basis of these different trials. And you see that there is a pyramid, and the most or the highly evidence-based study designs are the systematic reviews and the meta-analysis, which are summarizing the results of randomized controlled trials. So the study design with the highest evidence level are the meta-analysis and the randomized controlled trials. And then there is a downgrading with different study types down to the expert opinion. And we try to find the randomized controlled trials for patients with psoriatic arthritis. And in fact, in the flow diagram, most of the manuscript reported there are the randomized controlled trials. However, we also have to think about other influence on the reporting system, which we call the risk of bias. And then we report of whether we think that there is a risk of bias, whether we are unsure that there is a risk of bias, or that there is no risk of bias detectable. And then we are looking on different these domains, for example, for the psoriatic arthritis, on the joint, on the nail, on the skin. And then we report all these different findings based on the mode of action. All this evidence generation will then inform the next step of this process, which I would like to show you on the next slide. The next slide, please. And then this is a structured consensus process. So the task force then will discuss all the different evidence, the published manuscript, and will then provide in a structured process the recommendations. And you already have heard about some recommendation based on the self-management recommendations. And you see in this table as well that there is a level of evidence reported and the grade of recommendation that is referring to the level of evidence, the study design, the study types, which were found in the systematic literature review. And after this process has taken place, the task force then also provide a flow scheme so that the disease management process are depicted in different phases, starting with the first disease modifying an anti-rheumatic drug, and then going from a biologic and targeted synthetic DMARDs to a switching or cycle scenario. And you will see that in at least many of the management recommendations, which are at this stage intended to inform the rheumatologist. But then this, once this recommendation has been accepted, a next important step is that EULAR will also provide, with the help of PARE, the lay versions of this recommendation to support the third step in this process, which is the implementation process, which I'm depicting on the next slide. So the next slide, please. And here you can see it's a busy slide, but the implementation process is really a busy process as well. So we aim to disseminate at least the EULAR recommendation in all European countries and worldwide. And implementation is more than dissemination, so we really have to understand the resources, the healthcare system in a given country, the management, and also the prescription system. And therefore, we need all EULAR pillars to effectively implement these recommendations. And most of the EULAR recommendations quite nicely reflect also the national recommendation, because they are normally also based on a systematic literature review. So following these international guideline principles, EULAR recommendations provide a trustworthy source for the evidence generation, and provide also verified information, so that EULAR is aiming to really support the guidance of the patient, how to manage their disease, and provide information that you can use also in the day-to-day discussion with your rheumatologist, and to support the shared decision-making process. So I think, I'm not sure whether I have a last slide. Birte, yeah, here I would like to give you some examples. So I gave you the example of psoriatic arthritis. You will see that in the left column. So we have EULAR recommendations that are focused on specific disease type. However, we also have recommendations focusing on a more broader topic, for example, self-management, but also physical activity. And we also have initiatives on collaborative research and qualitative research. And if you are interested to check which recommendations have been published in the past, you can try the link below, where you will direct it to all the recommendations that EULAR have published during the last 20 years. So with that, I would like to thank you, and I think we will have an hopefully lively discussion, and that the Quality of Care Committee working on the recommendations all the year. Thank you.
Thank you very much indeed, Jutta. That was fantastic. It squares the circle for us, as I say, and brings us all the way around to everyone involved. A little reminder to everyone, excuse me, if you would like to put your questions into the chat box, or we will also open it if you want to raise your hand. We'll keep an eye and try and see the see you raising your hand there if you want to ask a question out loud. I just having a quick glance at the chat. And I think it's more a kind of a statement I think we can all relate to than a question in relation to having that delay between symptoms and getting to the GP is when you would have those conversations with family, friends, neighbors, the dog, the cat, everyone else, rather than going and getting the actual information that you need by going to see the GP. So I think we all need to work on getting that to a point where we can move it forward. So yeah, I agree with that statement, if it is one. I think Nadia, did I see your hand go up there? If I could ask you to unmute yourself.
Yes, hello everyone. Exceptional presentations. Thank you very much for putting in forward such important issues, and this is a very good theme this year for World Arthritis Day, because information is power and we need to have power ourselves as patients, and we need to use it in a very correct way. So my idea, as I was hearing on the presentations from health literacy to issues from the doctor's perspective, like in regards to empowerment of patient and the lay summaries going on with Utah, I was kept on thinking about the cognitive dissonance that patients face when they do have the information and they do become a bit more or a lot more literate, and they still face the dissonance between the point they're in and the point they can get to when they have the information, but still they are reluctant, they are hesitant in moving forward. Like, this is a matter more of motivation rather than information. So what can we do to help them, like, build on that? Because it is the information, but we need to, like, combine the two and, like, get those two together. Because, like, let me give you an example. We have very good recommendations from EULAR on non-pharmacological guidelines for osteoarthritis, for example. But when you give those to patients, they say, okay, oh, please give me drugs. I need drugs. Give me any kind of medication. I don't want to be in pain. But guidelines say physio, exercise, and lifestyle changes, like lose some weight, try to adjust your daily activities. So how do we, like, build on that and, like, bring the message and, like, motivate them a little bit more? Like, in daily practice, I have, like, we try to, that's my
I see where you're coming from. I think it's a combination really of the of Simon, your presentation, and Minnie, yours presentation, a little bit of that self-management and information. I don't know if either of you have a comment to make on that.
I mean, I was just going to say, what I always say to people is, you know, you need to give the information, but it's the what if. What does this mean to me? I think that's what we all want when we see information. What does this mean to me, and what can I do? And I think that is an extra step which we need to think about when we are developing information, so people can see, okay, I can trust this information. Then, okay, how do I apply that? You know, expert patients will automatically you know, probably gone through by experience how to do that, but I think we need to give more of those recommendations, as speak to a certain health professional, speak to a patient organisation, you know, directing people. So we need to make it as easy as possible. I mean, I feel like you may be able to add to that, but to me, that is the key link really between information and then what does this mean for people and what can they do. And again, it's coming around to making it super easy for people, so they don't need to do extra work during an already busy period of time.
Yeah, no, I'd completely agree. I think we need to remember that these are not, you know, easy easy to treat or simple conditions. They're very complex. And it kind of comes back to that circular diagram that I had with all the colors. I think it's really down to health professionals as well to make patients aware that resources do exist. At least in the UK, you only get 10 to 15 minutes with a patient in the rheumatology clinic. So it's really a case of also building time management skills from the clinician's point of view. Or like just leaving a link in the letter and telling them there's a few links here. We don't have time to discuss them today. And then next time, maybe ask them, did you find anything helpful? And I think also from my very first slide where I had the sort of education, access and empowerment, you can't get the result of all three without all three being there. And so I do think there's a room for better access as well to know about the different resources available.
And can I follow up on that, Minnie? Maybe it might put you on the spot a little bit, but that's lovely diagram as you described it yourself. I was taken by that because I think I've used all of those people at some point in that journey. How often would you think that at the moment that we're seeing patients in that central position when it comes to making informed choices?
Not enough.
Yeah.
But then again, I'm at a point now where I usually only see my own practice. Occasionally I'll see others, but it'll usually be people that I have learned from myself. So, and then I base my practice on theirs. So, but yeah, we still need to do more work in keeping patients, that shared decision making as well. We need to work on that as well, I think. Yeah.
I think that's important. And Simon, I just wanted to go back to something you mentioned there, the characteristics of low health literacy. I couldn't help but kind of see that RMDs tick a lot of the boxes that are there for those characteristics. So is there anything specific that we could be doing with our organizations to try and do that, or anything more we could be doing?
I think it is looking at those those groups of people, if you wish, and actually then trying to reach out and understand, okay, what are the barriers to them accessing information and how can we tailor particular information to them? I think what we see a lot is, developing information with your informed patients and your educated patients. I think, like Minnie said, education does not mean health literacy. You can have a really well-educated individual, but a really poor health literacy because maybe they've never needed to access information related to health. So it is targeting those audiences, understanding the needs and the barriers, and then working with them to co-create those solutions. I think that's the only way that you're really going to target those groups. I think that's why it's, the onus is on all of us to think about those, less heard groups, less involved groups of individuals, and then for us to actually target how we reach them and make sure that they feel included, feel involved, and have access to that information to help them make those choices and decisions.
Yeah, it really is, and thanks for that clear answer. Ute, if I could just turn to you, I really loved that fruit salad graphic. It was exactly as Simon said, that different way of learning, but to see something depicted that way and so clear and obvious, it makes so much sense. I've never seen anything like it before. But I wonder if you could just very briefly, I know we're running against time, but just to have a look at something that you mentioned where implementation is so much more than dissemination. If you could just emphasize that a little bit more for us, just on what you mean by that.
Yeah, implementation is to be think of at different levels. So for sure you have a national level because the healthcare system differ, at least in European countries. You have to think about in an organizational level. You also have to think about regional levels, because it's a difference whether you are working in a large city or somewhere in the countryside. And you have to provide your information based on these different levels, and you have to involve all the stakeholders. So it's not only the task of a scientific organization or a patient organization, organization. It's really the task of everybody working in the healthcare system. And we have to provide that's a referration to contextual factors, to provide stratified materials to address all the different facilitators and barriers that can help to really implement at each stages the recommendations.
Okay. I think that makes it a little bit clearer for everybody what we're looking to do. Susie, I've had a look in the chat. I don't believe there's any more questions there
No,
for
Peter.
us. No, I think with the time pushing on to 2 p.m. where I am, 3 p.m. where everyone else is, I think that might be an opportune moment to say thank you once again for all your input, your attendance. Just remind you all again about the different infographics and materials that are available to highlight World Arthritis Day. Coming up on Saturday is the day itself, and this webinar will be available on the EULAR YouTube channel as well. Have a look through the social media, our toolkit, everything else that is available there to share and to really raise that awareness and keep the conversation going. It's been a fantastic chat and conversation with three very, very good speakers here. Is there anything else you'd like to add, Susie, other than to thank our speakers?
No, I would like to thank also our speakers and just I take home this message that health literacy empowerment and can enhance shared decision making, which is very important for our health and our quality of life. Just that.
Excellent.
Thank you all for being here.
And thank you all, and thanks to everyone for putting it together for us on Pare's behalf. So to everyone, wish you very good health. Enjoy and acknowledge World Arthritis Day, and have good health for the rest of today. Take care. Bye-bye.